now, please welcome your host for today's webinar, Marlise Perez.
Thank you so much, James, and thank you all for joining us for our November public listening session. Today, our topic is going to be behavioral health services and supports. And so without further ado, we will move on through. My name is Marlise Perez. I am with DHCS, and I am the Behavioral Health Transformation Project Executive. So we can move ahead to the next slide. So as James already mentioned, this is being recorded. There is also live captioning available, and then tech support if that is needed. And then we can move to the next slide. So what we're going to be doing today is our traditional format is I will be presenting around the BHSS bucket today. I'm going to pause and ask some questions where we'd like your feedback, and you can put that feedback in the Q&A. And then I'm going to read some of that feedback, but please keep putting that feedback in as we are gathering all of that, and that'll be part of our summary document, which I'll talk about in just a moment here. Next slide. All right, so also you can send us an email with your comments after this listening session. If you want us to be able to include that in the summary document, you can send it to our BHT info email here. We are asking for your feedback by November 11th. That is just to be in the summary document. If you send it to us after that date, we're still accepting that feedback and we'll be reviewing it. It just won't be able to be included in the summary document. Next slide. All right, so we're going to just jump right in, and you can move us forward on the next slide. And so as you all know, we have been very busy at DHCS rolling out behavioral health transformation, which is a two-package bill that was passed with the Behavioral Health Services Act under Senate Bill 326 and the Behavioral Health Bond Act, which was AB 531. Both of those came together under Proposition 1, which was approved on the March ballot of this year in 2024. Today, we're going to be focusing on the Behavioral Health Services Act, and we do have other listening sessions around the Behavioral Health Services Act as well as the Bond Act. If you want to go back and review any of those sessions, those are available on our website. Next slide. And so what we're going to be talking about today is the bucket around behavioral health services and supports. So this is funding going to our county partners. There is a 35% of the funding that our county partners receive are in this bucket of funding. These are the areas, and we're going to go through all of these today, but early intervention, the children's adult and older adult system of care, outreach and engagement, workforce education and training, capital facilities and technological needs, and innovative behavioral health pilots and projects. Next slide. So with that, we're going to just dive right into the first area, which is early intervention. And so in the statute, you'll see here on the left is that 35% bucket. That is for that whole BHSS category. And then you'll see of that 35%, there's requirement in statute that 51%, at least 51% of the funding be used for early intervention services and programs. And then of that 51%, at least 51% of that must be used for children and youth that are 25 years of age and younger. There is some also flexibility in the statute that counties can transfer funding from their three buckets of the BHSS, the housing interventions, and full service partnership. And that's what this piece here refers to. They can transfer a maximum of 7% out of one bucket and into another for a total shift of 14%. Next slide. So in looking at early interventions, it's really important. The statute defines, and there's quite a bit of statutory definition already around early interventions. It's located in the Welfare and Institution Code, Section 5840. And this definition is really, it defines it to be designated to prevent mental illness and substance use disorders from becoming severe and disabling. But just want to have a really important piece up front. That does not mean that the individuals that are receiving early intervention services, they do not have to have a behavioral health diagnosis in order to receive these services. Early intervention is really, if you'll see here on our chart, it really covers the areas of indicated prevention and also case identification. And that really has that element of early treatment and supports as well. And so for the programs, those early intervention programs for children and youth, they really are required to be designed to meet their social, emotional, developmental, and their other behavioral health needs along this continuum. Next slide. So focusing in on our kids and looking at that 51% of the funding that needs to focus on the children and youth, there are areas that must be prioritized. And so these funds must prioritize childhood trauma. And you'll see here ways that that can be done, and that's addressing those root causes around adverse childhood experiences or other determinants of health. And you'll see here different strategies that can be focused on with youth experiencing homelessness, justice-involved youth, child welfare, and other youth that are at risk of developing serious emotional disturbance or substance use disorders, and then also children and youth in populations that already have identified disparities. Next slide. So just want to jump into feedback right away. So our first question for you today is early intervention services for children and youth is an integral part of the BHSS funding. What models and services have been effective in serving this population? And so with that, if you could just provide your feedback in the Q&A, and I'm going to read through some of it. I'm not going to be able to get to all of it, but once again, please note that we are capturing all of the feedback. We have here community-defined evidence practices from the California Reducing Disparities Project. School-based services or services that are co-located on school sites. Early childhood mental health consultation services. Parents as teachers. Triple P. I'm seeing Triple P a few times here. Attachment-related services. Focusing on the relationship between the child and the parent and or caregiver. Work with early education centers and Head Starts. A lot around school-based services. There's a model highlighted here from Alameda County, underserved ethnic and language populations. Lots of great models here coming in. Family partner, peer, youth advocates, family advocates. Lots of comments in about community-defined practices that are targeting areas. Seeking safety, once again, a lot around Triple P. Functional family therapy. A lot around peer youth. Also, I'm seeing a lot around parenting education services. Some great examples around using technology, such as texting features of their 24-hour hotline. Great. And the last one I'm just going to read right now is the community-based group developmental play groups. So I'm going to just stop on that one for now, but please feel free to keep putting your feedback into the chat because once again, we're collecting all of that. Okay, I'm going to move us on to the next slide, and we're still talking about early intervention. And so we do want to just call out that there are new areas that have been expanded. We have been doing early intervention services under our Mental Health Services Act, but really wanted to highlight the additions that come from the Behavioral Health Services Act. You'll see here the addition of self-harm. There's also a lot more clarity around schools, adding in suspension, expulsion, being referred to an alternative or community school. You'll also see the addition of overdose, once again recognizing that substance use disorders are now a part of the Behavioral Health Services Act. And then also mental illness in children and youth from social, emotional, developmental, and behavioral health needs in early childhood. So these are all of the whole focus of early intervention to really be reducing these adverse outcomes. Next slide. So for the early intervention, there's 3 program components, and these are outlined in statute. Once again, back to that Welfare and Institutions Code, Section 5840. And as we mentioned earlier, that's where that definition is also contained. But these 3 areas of focus are outreach, access and linkage to care, and then mental health and substance use disorder treatment services and supports. So any of the services that are being provided for an early intervention need to be falling into one of these component categories. The department does have the authority to add additional components. However, we're not adding at this time any additional components, but that could come later on down the road as BHSA continues to unfold over the course of many years. Next slide. So I just want to walk through those 3 component areas. And so the first is outreach. And so once again, there's a lot of already definition in the statute that really outlines who the outreach activities can be utilized with. I do want to just focus, as with all of BHSA, that outreach has to be directed toward priority populations, and that includes older adults and youth as well. That doesn't limit, though, the outreach activities just to those populations, but it cannot be directed to an entire population. The whole goal of outreach for early intervention is to really be able to have an individual focus. And so that outreach has to have the goal of identifying individuals for those other 2 components that I talked about, for access and linkage to services, and also for treatment and supports. So the outreach must be able to connect individuals directly to either access and linkage programs or to these mental health and substance use disorder treatment services and supports. However, just want to make sure it's noted here, should the individual wish to be connected to the services. So recognizing that outreach activities may be occurring where that individual does not choose to then either have additional services or have that access and linkage. However, that is still a allowable use of the funding for that service, that outreach that's occurring. Next slide. So that second component is around access and linkage to care. And so once again, each of the county's programs have to have this component. And once again, this is really to have this available as early in the onset of these conditions as practical. You'll see here to the right what these types of areas are around access and linkage. This is not a limited list. These are just some examples, but you'll see here could be the scaling of a referral to the Early Psychosis Intervention Plus program, coordinated specialty care. I know there were some questions about that in the chat. Other similar EBPs or community-defined evidence-based practices that could be around early psychosis, mood disorder detection and intervention programs, work around screening, assessment, referral. This could also include telephone helplines, mobile response. Once again, this list is not exhaustive, but these are some of the areas that it would include. Next slide. So that third component is around mental health and substance use disorder treatment services and supports. I do just want to reiterate one more time that early intervention services, the individual does not have to have a diagnosis in order to be receiving these services. But this component really is to ensure that there are services that are effective in preventing the mental illness or also the substance use disorder from becoming severe. And so this component really needs to have services that are effective also at meeting the cultural and linguistic needs of diverse communities. This may include services to address first episode psychosis and services that prevent, respond, or treat a behavioral health crisis or activities that decrease the impacts of suicide. Next slide. So next, what I want to talk about is around stigma and discrimination reduction. So stigma and discrimination reduction, these activities align with population-based prevention activities. So these are not funded under early intervention. These would be funded under other funding sources, such as counties receive substance abuse and mental health services, block grants. There's also the California Department of Public Health does have funding underneath Proposition 1 for population-based prevention. They're going to be rolling out their guidance around that. And there's also opioid settlement funds and other prevention dollars that could be used for stigma and discrimination reduction. And so we are working with our partners at the California Department of Public Health around their guidance for population-based prevention funding. We've been sharing with them our initial thoughts around early intervention, and our goal is really to make sure that it's very clear what is falling within their funding and then what is falling within the funding under early intervention. Next slide. All right, so as I mentioned earlier, there is other categories that the department could define. So beside the broad categories of outreach, access, and linkages to services and supports, and also the bucket around the mental health, mental health and substance use disorder category, are there other categories of early intervention that DHCS should consider having guidance? And my team could actually move back a few slides where we have the three components, just so you can see them. That would be great. And I can let you know when you're at the slide. There you go, perfect. So we have these three buckets here outlined. Are there any other categories that you feel that we should add in? And if you could just put your thoughts in the Q&A, that would be great. All right, I'm seeing a lot around social determinants of health, especially in regard to environmental trauma and community violence, technology-based interventions, digital mental health literacy, peer outreach and advocacy, engagement and navigation to services and housing, ensure that caregiver family support sessions are covered. Might include educating family members on substance use or mental health related risks. This comment is no additional components, but think it's important to call out that crisis services are allowable in this category, which is correct. Community partnerships to ensure counties are partnering with community-based organizations and trusted stakeholders. I'm seeing a lot around housing, um, also home retention and early stable housing. More around technology as well, also with a lot around utilizing texting or mobile apps. I'm also seeing, excuse me, a lot around training and different comments around training. I do want to state that at DHCS, we'll be providing a lot of training in general around the Behavioral Health Services Act, but I do just want to note all the various comments coming in around training and the importance of it. Peer-to-peer chat services, lots of, once again, around peer and peer support, targeted grief and loss services. And I'm just going to end on this one, the school-based interventions. I have seen quite a few comments around schools as well. So once again, feel free to please keep putting your comments and feedback in the Q&A, but I am going to move us on to our next slides, please. All right, so next we're going to talk about the early intervention requires an evidence-based practices and community-defined evidence-based practices list. So if we could move to the next slide. So that is contained in statute. It's going to be released by DHCS biannually, and we will be working with our partners at the OAC as well as counties and other stakeholders. This is going to be a reference tool. It is not going to be an exhaustive list. It will be non-exhaustive, but it will have evidence-based practices as well as community-defined evidence-based practices that a county may implement. Now, through BHSA, there are a lot of new accountability measures that come with the Behavioral Health Services Act. So if a county is demonstrating gaps in services or is not meeting the performance measures or struggling to do that over a course of time, DHCS may require a county to implement a particular EBP or CDEP from this list. Next slide. So as we are identifying, what to include on our first release of the biennial list, you'll see here, these are just some of the sources that we're going to be leveraging in developing the list. And I do just want to call out the Children and Youth Behavioral Health Initiative. That is a required list in statute, but these are other lists as we have been talking to subject matter experts and also with our own expertise in-house that we're looking at utilizing in order to develop this list. And once again, this is just for early intervention services. Next slide. So as we are looking at this list, some of the kind of guidelines that we're looking at is really making sure that it has just really well supported evidence. And that's for the EBPs. But for the CDEPs, really making sure that it really impacts the community. We recognize that not all CDEPs have evidence behind them or research, but that doesn't mean it isn't still a CDEP that really works well for specific populations or communities. We want to make sure that it has cultural evidence, and this is for EBPs and CDEPs. We're going to be looking at the different populations served, risk and protective factors, and then what type of program does this EBP or CDEP work for. Next slide. So are there any additional considerations that DHCS should add for inclusion in the biennial EBP and CDEP list? So if we could just move back one slide so you can see that. Is there anything else we should be looking at as we're, looking and evaluating if a EBP or CDEP should be on this list? And with that, I will open up the Q&A. Costs for training and sustainability. Maternal well-being and child's mental health. EBPs and CDEPs that reduce mental health disparities among underserved, unserved, and inappropriately served populations. Geographic location, whether it's rural, urban, or suburban strategies. Seeing more comments coming in around that geographic location, a lot of comments around the rural population, some of their limitations, especially pertaining to access or drawing down startup costs. Implementation support, developer information. Consider age groups, including the TAY population, transitional age youth, and aging or older adults. An awareness that not all EBPs are appropriate for diverse communities. Remote versus in-person practices. Maintain consideration for EBPs that require extensive training and fidelity, and impact of workforce challenges that counties and community-based organization partners have. Language access and sustainable funding to practice in threshold languages. Also just seeing a lot of comments in, and I just want to remind everybody, this is a list that counties can utilize for EBPs and CDEPs, and those CDEPs, just want to be clear, those are coming from local communities and from specific populations as well. And the last one I'm just going to read is streamlining data reporting with regard to fidelity. Great. Well, thank you so much for that feedback. We are going to move forward in our slides. So next, we're going to talk about the children's, adult, and older adult system of care. So we're going to be moving out of that 51% of the bucket under BHSS. And now we're going to talk about those other components that can also be funded within the BHSS component. Next slide. And so the children's, adult, and older adult systems of care are services for individuals that are not enrolled in full service partnership. And then also to be clear, that do not include housing interventions. So those are services that are funded under the other components. And so these activities will largely remain the same as what counties were funding under MHSA under that CSS bucket, with a few little differences. One is the addition of substance use disorder services, and then that the eligible and priority populations have been modified from MHSA to BHSA. So those are the main differences there. Next slide. The next area I want to talk about is outreach and engagement. Next slide. So outreach and engagement, this is included under the BHSS component. And so outreach and engagement activities are those that reach, identify, and engage individuals and communities in the behavioral health system, including peers and families, and to reduce disparities. Next slide. So for outreach and engagement, really want to make sure that there's, a clear distinction here, because as we talked about just a few minutes ago, outreach is included underneath early intervention, and we already walked through what those activities look like that could be funded under early intervention. If you were with me last week, we talked about full service partnership, and there's also outreach activities that are allowable under that component as well. And so what we're really talking about here for this part of outreach and engagement is it is really unique to a broader engagement of unserved or underserved populations. And once again, if they're not already a part of early intervention or full service partnership, this is where this funding can be utilized. It can also cover activities for that housing interventions bucket. So that could be around housing navigation or other outreach services as well. Next slide. The next component we're going to talk about is workforce education and training, which I'll just refer to as WET. So if you're familiar with the Mental Health Services Act, WET is an allowable activity now. However, this area has a lot more guidance that I'm going to walk you through for BHSA. And so you'll see here, and this is once again outlined in the statute, these are some of the areas of WET that the funding can be utilized, once again, around that whole workforce education, recruitment, professional licensing and certification, loan repayment, retention incentives and stipends, internships, apprenticeship programs, continuing education, and then any efforts to increase the racial, ethnic, and geographic diversity of the behavioral health workforce. There are, a lot of information that I'm going to be sharing with you today, but we're also going to be providing a lot of guidance in our policy manual about allowable activities for WET. So next slide. So first, there is around workforce. They are going to, our county partners are going to be required to report to us their workforce needs and strategies. This is a part of the county integrated plan. And so we're really recommending that as counties are putting this information together in their integrated plan, that it really doesn't duplicate what is happening under if counties are opting into the BH Connect waiver. Now, I do want to note that we are not going to be requiring a separate workforce needs assessment. That is something that is currently happening under MHSA that will not be occurring under BHSA, as the information that is required for BHSA will once again be in that county integrated plan. Next slide. So funds may support any fees associated with preparing for, applying for, or renewing a license. Funds may support any activities that also enable provider testing for a license or certification. All of these, though, have to be for the behavioral health workforce, very specific to that for county-funded activities. Next slide. You'll also see here some information around how WET can be used for loan repayment. And these are some of the minimum requirements for county loan repayment. You'll see here, once again, as I just mentioned, they must be employed in the public behavioral health system and commit to a certain term of employment. You'll see here there's different maximums and minimums depending on alignment, if there's alignment with BH Connect. You'll also see that counties are going to have the flexibility to define the terms of employment. We have an example here of how that could look. Counties must also ensure the terms of employment are met and have a process to recoup funds if the commitments are not met. Next slide. Also, another area is around retention incentives and stipends. And so once again, these incentives and stipends must be for individuals that are only working in the public behavioral health system. So that means through our county partners. And once again, this could be reimbursement for expenses, either all of that or a portion of that as well. And then for these training and educational programs where individuals receive incentives or stipends, they may include those funded by the Behavioral Health Services Act or other funding sources. So once again, you'll see the minimum requirements is that they're employed or training in the public behavioral health system, they commit to that term of employment, and that the counties must ensure service commitments are met. Those are the minimum requirements. Counties may add additional requirements as well. Next slide. So once again, as I just stated, counties will have the flexibility to define which expenses are eligible for retention incentives and stipends and the level of payment. You'll see here, there's some examples around retention incentives and stipends, which could be in the form of scholarships, recruitment and retention bonuses, or coverage of costs associated with maintaining employment. Next slide. All right. So I just ran through a lot of wet activities pretty fast. I apologize for the speed there. But are there other wet activities that DHCS should consider including in the proposed policy? So if you could provide any comments in the Q&A. While you're putting in the comments, I do just want to clarify because I'm seeing just some general comments. I do want to acknowledge under Proposition 1, there is funding for workforce that's going to HCI, and they have been releasing some preliminary guidance around that funding. WET is different because WET is being controlled by the counties at the local level. So first feedback here that we're getting, let's see here, mentor programs. Recruitment, training, and support for peers and family members working in the public behavioral health system. I like how that person added that because that is the main requirement that I probably repeated 4 times. So good job on that one. Let's see here. Using WET funds to cover education and tuition costs for bachelor's and master's program. I do just want to recognize for everyone putting in comments. I went through it really fast. Some of these things are covered, but I appreciate you putting in the feedback. Mileage reimbursement for internship programs. Compensation stipends for individuals who are competent and providing direct services in a second language, especially if it's a threshold language. High school pipeline activities to educate high school students about careers in behavioral health and help grow community workforce. Funding for underserved workforce with disabilities. Comments in here about WET applying to staff of nonprofits who contract with the public behavioral health system. Employee recognition programs. Career growth for peers in the system. Also providing equitable compensation for peers. Reimbursement for differential pay for providing acute crisis services and working in programs after hours. A lot more here around peers, supports for hiring and training peers, specifically peer certification. Professional development for transitional age youth. Specific funding for deaf employees to have interpreters as partners in the workplace. Continuing education. Reimbursement for trainings or programs for job satisfaction. And I'm going to end on this one. Public behavioral health system hosting community-led activities such as trainings, summits, conferences for workforce development for K through 16 mentorship. Great. Well, feel free to keep adding in your feedback. Once again, we're collecting all of it, even if I didn't read it out. So thank you for continuing to add that. But I am going to move us along. So next, I want to talk about capital facilities and technological needs. Next slide. So I'm just going to use the abbreviation. I hope that's okay. But for CFTN, it is included under the BHSS funding component. For these projects, counties do not have to have a separate plan or proposal. And for restrictive setting projects, we do not require the least restrictive settings demonstration. Also want to note that the statute allows counties to use their CFTN funding as the required match for the bond behavioral health continuum infrastructure project awards. Next slide. So around CFTN, around technological needs, some of the allowable expenditures, these projects for technological needs need to increase the client and family empowerment and engagement by providing the tools for secure access to health information and modernize and transform clinical and administrative information systems. So that is what these projects should be doing. Some examples of projects that meet these goals are around electronic health records, client and family empowerment and engagement projects, and then there's other technological projects as well. Next slide. So for these expenditures, they should be used for land and buildings. This could include administrative offices, And so some of this more specific uses could be acquiring and building on land that is county owned, or maybe constructing or renovating buildings that are or will be with this funding county owned. Having a capitalized repair or replacement reserve for buildings. Also could be renovating buildings that are privately owned, but only if it's dedicated and used to provide behavioral health services for the county. And then the last one, to acquire facilities not secured to a foundation that is permanently affixed to the ground. So that could be examples around buses, trailers, or other vehicles like that. All right. Also, some of the other additional requirements for the use of the funds is, once again, these are only allowable where public behavioral health services are provided. And for these, where land is being acquired or construction renovation is happening of buildings, those public behavioral health services need to be provided for a minimum of 20 years. Of course, they must meet any federal, state, or local laws and regulations. Um, and then also, if a county is leasing or renting to own a building, they have to provide information on why, purchasing the property is not feasible. And once again, all of this will be described in their county integrated plan. Next slide. These are some examples of where funds cannot be used. So these are unallowable expenditures. So this is where the purpose of the building is to provide housing. So once again, there is under the housing intervention bucket some funding for capital, but it is not to be funded under CFTN. Anything for housing, master leasing or renting, purchase of a vacant land with no plan for building, acquisition of land, and or buildings where the owner on record is a non-government entity, and then for furniture or fixtures not attached to the building. Next slide. So what other types of allowable expenditures should DHCS consider for CFTN? So once again, if you could provide any feedback in the Q&A. We comment in about vehicles. Funding for technology-based intervention, smartphone application licenses. Navigation or wellness apps. Funding for Wi-Fi hotspots. Lot coming in around technology. This one is technology to support implementation of software that supports progress toward the development of the NCQA health plan infrastructure. Lot coming in around data systems. Upgrading technology and equipment to align with modern times, to allow for hybrid meeting, to include updated audio, video, etc. Making sure buildings are accessible. Landscaping and beautification costs of new projects to benefit community acceptance, helps with community integration of programs. Residential sites for clubhouses. Funds for Wi-Fi acquisition to needy individuals and families to increase ability to access services. And then I'm going to end on this comment, just more comments around data infrastructure. So once again, feel free to continue to put your feedback in the Q&A, but I am going to move us on just to our last few remaining slides. Next, innovative behavioral health pilots and projects. Next slide. And so under BHSA, counties can pilot and test innovative behavioral health models of care programs, and they actually can test these models through all three of the funding components. And the whole goal of innovative pilots and projects is to, continue to build out that evidence base for effectiveness of new statewide strategies and just really to test things as we are really great doing in California around innovations. These innovative pilots and projects do not require a separate plan or approval. They will be a part of the county integrated plan that I've been talking about, that our county partners will be submitting to us every 3 years. And so that will be a part of that, but there will not be a separate plan for these innovative pilots and projects. Next slide. Great. And so with that, we are at the end of our BHSS bucket. So thank you so much for just joining me through that. We do have resources here for you in case you haven't looked at these yet, but we have our DHCS website where we have information about behavioral health transformation. We have a lot of frequently asked questions. We will have these slides will be posted on the website underneath the public listening sessions. All of our previous public listening sessions will also are posted there, as well as our summaries of all of the listening sessions. Other stakeholder groups will be posted there as well. And also, if you have any questions or other feedback that you want to submit to us, you can submit it to our BHT info email box. And then I also just want to state, as I have in other listening sessions, but since I have you all today, we will be releasing our first module of our draft guidance for our policy manual. That will be coming out by the end of 2024. So please look for that because we are asking for your feedback. It is draft. There will be guidance around how you can provide your feedback and the timeframes for that as well. But for all of our policy, we'll be releasing it in modules for our larger BHT policy manual. So with that, thank you so much for attending today. Once again, this will be posted on our website, the slide deck, and then our summary document as well. So with that, have a great rest of your day. And thank you so much for all that you do in behavioral health in California. Take care. Bye-bye.